Next speaker is Dr. Josh Lindauer. Dr. Josh is a chiropractic physician and owner of Health First Rehab, which he established in 1999 with practices in Yarmouthport and Mashpee. He holds a bachelor's degree in applied human anatomy from the State University of New York in Auburn and graduated cum laude with a Doctor of Chiropractic degree from New York Chiropractic College. He holds an advanced certification in whiplash and brain injury traumatology from the Spinal Research Institute of San Diego and was certified as a Cox flexion distraction practitioner by National Chiropractic College in Chicago. He holds additional certifications in strength and conditioning and golf conditioning. Dr. Josh was a former team chiropractor for the Cape Cod Crusaders Soccer Club and a repeat exhibitor at Viva Palooza. It's a health fair that Emerald Physicians did for many years. And today, Dr. Josh will present a chiropractic approach for pain relief. Thank you, Dr. Josh.
All right. Okay, is my mic on? Can people hear me? Awesome. Good afternoon. I am humbled and honored to be here to speak with you today. Before I get started, I'd like to ask a question. Are there any active military members or veterans in the audience today? If I can ask you to stand up. I think we should give these folks a round of applause. Thank you so much for your service to this country. We really appreciate it. Remain standing, please, pretty please. And I'll ask everyone else to stand up if you would. So we've been sitting for a little while, and our back's probably starting to get stiff. So I think it'd be a good idea if we just do a couple stretches together. I'm going to do a few stretches. I'll ask you, you're welcome to join me. I will ask you if there's any symptoms, if this is causing you any pain to do any of the stretches that we do, please discontinue. So let's just start with some head rolls. We're going to take our head from one side. We're going to roll it to the other side. We'll just loosen up the neck a little bit here. Excellent. Again, any pain, just discontinue. Okay, we're going to take our shoulders and roll them forward. Make sure you get your arms involved. We want to get a little bit of circulation into the arms. Fantastic. Let's go back. Perfect. And the next one we do is, I call it a butterfly stretch. So you're going to take your hands in this position. We're going to come forward, and we're going to reach back. Now, when we reach back, we want to feel those chest muscles open up. Feel those pec muscles open up. Fantastic. Okay, shake your arms out. Shake your legs out. All right, you folks can have a seat. Whoa, 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 what happened there? Okay, so you saw that, right? So when I say the word chiropractic, what is the first thing that comes to your mind? Okay, now that's supposed to happen. Most people think when they go into a chiropractor's office, we're going to walk into my office, I'm going to shake your hand, I'm going to lie you down and start snapping and cracking your back. Well, I should tell you, that is far from the case. I'm hoping that through this presentation, you'll learn a little bit more about chiropractic and the understanding that chiropractic is much more than just snaps and cracks. So chiropractic is a portal of entry healthcare profession. What does that mean? It basically means you do not need a referral to see me. We can be the first point of entrance into the healthcare system. Our training, chiropractors we have 4 years of undergraduate study, then we have 4 years of chiropractic school, graduate study. The first 2 years mimics that of medical school, with an emphasis on musculoskeletal conditions, as these are the conditions that we normally treat. The last 2 years, we're learning chiropractic manipulative therapy, rehabilitation protocol and theory. And the fourth year, we're actually in an outpatient clinic. Now we treat patients in that setting. We use the same physical, clinical, laboratory, and diagnostic procedures as your medical doctor would. We don't have any fancy testing that we do. We use all of the standard testing that a neurologist would use, that an orthopedist would use to make our final diagnosis. But we're mostly concerned with the musculoskeletal conditions, and how those disorders of the musculoskeletal system affect our overall health. So what are some of the common conditions that we treat in a chiropractic office? We have to know a couple terms before we get to the conditions. One is a subluxation. How many folks have been to a chiropractor before? Wow, that's fantastic. So you probably know what subluxation is. It's kind of our catch term. Basically, a subluxation means it's an abnormal alignment. It's an anatomical malalignment or a malposition of one bone on another bone. The sister, oh, I'm hitting the wrong button, sorry. The sister term to that would be intersegmental joint dysfunction. This is the physiological part. This is the abnormal function. So we have abnormal alignment or misalignment and abnormal function. If we look at some of the issues that we treat, some of the conditions that we see in our office, low back pain, neck pain, cervicogenic headaches, we see that at the core of these, a common finding is intersegmental joint dysfunction or subluxation. So what are the goals? When you walk into a chiropractic office, what are my goals with you? First, normally people are walking into my office because they're in pain. So we want to reduce their pain. Once we get their pain down, we're going to restore and improve function. We want to prevent recurrence of injury, and we also want to promote optimal health. We have to understand what pain is. What is pain? Pain is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage. It is subjective. We all experience pain differently, and it's based on a lot of different cultural, developmental factors. There's a lot of factors that go into it. But it's really hard. When I have a patient come into my office and I have to have them fill out what's called a patient pain form, it's really hard to answer that question. Well, geez, my pain changes all the time. It might be a 2 out of 10 one day, an 8 out of 10 of another day, and your pain is different than my pain. So we try our best to qualify for that, but it's a difficult thing to qualify. So now, pain pathways. There's numerous pain pathways, and we could spend literally a week in a symposium on pain pathways and pain theories. So I'm going to just skim the surface. I want to keep this kind of simple, a simple understanding of how pain works. First, what happens, there's a noxious stimulus, an abnormal or an irritant that potentiates tissue damage, that's either actual or potential tissue damage. Once that happens, we have this physical response. We have these receptors. It's in our skin, in our joints, in our organs that start to fire up, and they stimulate a chemical reaction. We have these receptors. There's all of these chemicals in pain. There's gamma-glutamine and substance P that is our neurotransmitters. They're taking those chemicals, taking that impulse through our nervous system and up to our brain. And when it hits our brain, what do we have? We have an emotional response. That emotional response is what we know of as pain. And this is typically where our vocabulary changes a little bit. This is when, whoa, this is kind of when we get really upset. It's an emotional response to something that's irritating us. Once that happens, what does our nervous system do? It goes into a triage. So we think of our brain as being an ER doctor. There's a little ER doctor that lives in our brain. And our ER doctor says, well, let's say a patient comes in and they stub their toe. And my ER doctor, my brain says, it's not that big of a deal. I'm just going to shake it off and we're going to move on. Let's say you get hit by a Mack truck. Well, there's going to be a different response. Your body is going to go into a different response. Your ER doctor say, oh, wait a minute, there's a lot going on. We're going to tap into our internal pharmacy. We have all of these chemicals within us, our natural chemicals within our body, to help to stabilize our body and reduce the pain in area when we're under a lot of stress. So two things I bring to mind. When we have a great deal of stress, or let's say we got hit by that Mack truck, we have this adrenaline surge and cortisol surge. These are stress hormones. So just a quick experience of mine. About 4 or 5 years ago, I was driving down Race Lane. I was with my family, and a truck had hit another truck, and then it flipped over. So I got out of the car, and I went over to help the people in the truck, and the woman got out of one of the vehicles and started walking across the road. And I looked at her ankle. Her ankle was deformed. There was obvious deformity to her ankle. She had broken her ankle, but she was able to go from one side of the road to the other side of the road. That is the power of our pharmacy, our internal pharmacy. Basically, she didn't feel it at that time. That's a protective mechanism. That's a good mechanism. However, if we have this, I hit the wrong button again. If we have this inflammatory response and adrenaline and cortisol that lasts too long, then that starts causing additional problems. So we'll talk a little bit about that. So what are the causes of musculoskeletal pain? There's obvious causes. There's physical causes, right? Acute trauma, poor posture, improper lifting. One thing that I see in my office all the time, something called movement apprehension, and this is real. So a patient comes in, they hurt their back. They come in to see me, they're afraid to move because of their back pain. Weeks go on, Days go on, weeks go on, they're healed. Their back is healed. The tissue is healed, but yet they're still afraid to move. That's a real issue. We want to make sure that people know when you're in pain, it's actually essential to move. It's okay to move, even when you're having pain, and we'll discuss why. Chemicals. When we have poor diet, poor nutrition, alcohol, dehydration, any toxins that we put in our system increases our pain sensitivity. So if we have a nice, healthy diet, maybe we can tolerate that pain a little bit better. If we have a lot of toxins flowing through our body, then we're going to have more sensitivity or less tolerance to pain. So here's the emotional part. So we have physical, chemical, and emotional. I've been in practice for 20 years, and I can't emphasize the importance of the emotional component of pain. I can do everything physical for a patient, but if they come in, they're anxious, they're depressed, they have mood disorders. If they're stressed out, their pain is going to last longer. I can have two people with the exact same back problem, one happy and ready to get back to golf, and the other person depressed and woe is me, I can't deal with this. Who do you think is going to feel better sooner, right? So without question, there's an emotional component to pain. This comes back to that cortisol. Remember we said cortisol. Initially, cortisol is a fantastic anti-inflammatory, right? So if we get hit by that Mack truck, our cortisol is going to be increased, and that's a good thing. The long-standing results of cortisol have a numerous negative or bad effects on our system. And so now we have this increased sensitivity for pain because we have this long-standing cortisol. And the second part of cortisol is if it's sitting around for long enough, we have all of these processes that occur that actually slows healing. So when we're under stress, what happens? We have an increased sensitivity for pain, and we have a slower healing time. So we have to take that into account when we're treating patients. So components of musculoskeletal pain. One is kinesiopathology. The term pathology basically means just abnormal function. So we're talking about joint function, hypermobile or hypomobile joints. Joints that move either too much or too little, that gives us joint pain or stiffness. And almost invariably, you can't have joint pain without some type of a muscle activity with that joint. We call that myopathology. This is weakness, abnormal function, poor posture. And so let's talk about what poor engrams are. An engram is a muscle memory pattern. So if I could ask you all to take your hands to your side, cross your arms, like very comfortably, just cross your arms. Like you're at a party or you're hanging out. Let's drop your hands for a second. Cross them the opposite way. Put your other hand forward. Does that feel normal? Now, some people are going to say, oh, yeah, that's perfectly normal. And others will say, geez, that feels really, really weird. That's an engram. We're building up a muscle memory pattern, a neuromuscular pattern of movement. I learned to ride a bike at 8 years old. I stay off that bike for 35 years, and I jump on the bike 35 years later. Do I have to relearn how to ride that bike? My body has built up a memory pattern, a neurological, a muscular memory pattern. Unfortunately, posture can develop memory patterns as well. There can be a good memory pattern or an aberrant or an abnormal memory pattern. So for example, if we look at this picture here, this person, I've been sitting all day, I'm crouched in front of a computer, and here's my position. If I'm in that position for long enough, my body says, well, geez, that must be normal because it's been like that for so long. My chest gets tight, my back gets weak, my shoulders start creeping up towards my ears, and let's just imagine what can happen. What type of symptoms is this person going to have? Headaches, neck pain, shoulder pain, back pain. I think Dr. Lepla alluded to it can actually cause decreased lung capacity. So there's a lot of things that happen with posture. We have to correct that posture as part of a treatment program. Now, about 3 or 4 weeks ago, there was an email out from Cape Cod Healthcare, which you all should have gotten. And any golfers? Is there any golfers? It's must-read article. Dr. Houle put an article out on Tiger Woods' return to golf after his back injury. Did anyone read it? So exactly, it was a great article. So one of the things is that he talks about, Dr. Houle talks about, we have this sedentary lifestyle. We're sitting all the time. And what happens when we sit all the time? These muscles get shortened, these muscles get weakened, and these lead to these postural imbalances, aberrant or abnormal postures. So these are things that we have to take into account when we're treating patients. The next thing, we have neuropathology, nerve pathology. A nerve can be either compressed or stretched. Either way, we're going to have symptoms, pain, numbness, tingling. If we have neuropathology at the top of our neck, we can have what's called cervicogenic dizziness as well. All of these things, if we let them sit around, they build up these metabolites. These are what's byproducts of metabolism. Lactic acid builds up. That's the kind of the sore, achy feeling you get after working out in the garden on Monday. That's how you feel the next day. Inflammatory cells, cellular debris. What does that happen to our pain sensitivity? Okay, it increases our pain sensitivity. So we got to clear that out. How do we clear it out? We have to move. If we let it sit there long enough, that changes into histopathology. Basically, histopathology is Dr. Lepola's whole discussion was on histopathology. Degeneration, disc desiccation, or drying out of the disc material. This is where we get the bone spurs around our joints, adhesions, and eventually failure if we don't do something about it. The term that we use in the chiropractic profession, a sequela of these components, and kind of an all-encompassing term is what's called a subluxation complex. Now, we'll put vertebral subluxation complex, but the complex can happen in any joint, in your elbow, in your shoulder. When these things happen, either individually or as collectively as a whole, what does it give us? It gives us pain. So we want to address all of these issues when we're treating a patient. Now, we have this pain. What are we going to do about the pain? Now, this is just a skimming the surface. We're not going to go into great detail, but just a quick understanding. We have these receptors. We talked about the nociceptors. Those are pain receptors. We also have mechanoreceptors, which are touch and motion receptors. And a good way to understand this is through what's called the gate control theory of pain. How do we stop the pain receptors to get in by stimulating mechanoreceptors? So this slide, if I put my hand on a hot stove, what's the first thing that I do? I pull it off. My body tells me, you got to get it off of there. What do I do with my hand? Ow! Boy, that really hurt. Or if it's bad enough, I'll take, maybe it's too much damage, and we have injury to that. Oh, man, that really hurts. Or let's say we have a sore shoulder. Oh, man, that's sore. What do I do with my hands? Boy, that is sore. Or, man, I got to move that around. What is my body trying to do? Intrinsically, primitively, it's trying to stimulate these mechanoreceptors. If we stimulate enough mechanoreceptors, we'll drown out the nociceptors. And that's through the gate, not used to this one. The gate control theory. If we stimulate all of these mechanoreceptors, we're going to shut off the gate for the nociceptors to make it to our brain. And what happens with that? Decreased pain. So we have these outside mechanoreceptors. How do we stimulate those external mechanoreceptors? That's anywhere, massage. TENS unit. How many of us have used a TENS unit? Pretty common, right? That's the mechanism. That's why we're using those. Skin irritants like BioFreeze. You'll see a little bit of BioFreeze in your packets today. Hot and cold do the same thing. So all of these stimulate those outside mechanoreceptors. Now, how do we stimulate the inside? That's where we come in. That's my bread and butter. It's my claim to fame, the chiropractic manipulative therapy. When I manipulate the joints in the back, we stimulate a great deal of mechanoreception, and if we can stimulate those mechanoreceptors, there goes the pain. Other ways to stimulate the inside mechanoreceptors, just move. We have to move. When we're in pain, we decide, well, we're not going to move. We actually want to move. We want to stimulate mechanoreceptors. That's massage, aerobic activity, movement therapy, yoga, Pilates, any of those are going to stimulate mechanoreception. So now let's talk specifically about the chiropractic adjustment. So chiropractic manipulative therapy, all of us have gone to a chiropractor and got adjusted. That's essentially what we're doing here. When we use this type of adjustment that you see here, we call that spinal manipulative therapy. Let's go into detail about that. So we want to establish as much range of motion in the joint. We have this active range of motion where I move my head back and forth, okay? Then I go into passive range of motion. I can move it so far, but I can actually ask it to do a little bit more by moving it, by having someone help or stretching ourselves with some help there. Then we get into this range of motion, which is the end range of motion. It's called a paraphysiologic range. It's this range of motion that creates the most function out of the joint. We're trying to establish more function, and so through the manipulative therapy, this is typically how we accomplish that. So when I treat a patient, they're all pre-screened. We've gone through our evaluation. We've gone through the testing. We make sure that you're a good candidate. We don't just lie everyone down that walks in the door and start snapping and cracking. You have to be qualified. You have to be a good candidate for this type of therapy. We do a pre-setup. I go to the passive range of motion. You see me just that little thrust here. That's when you get the crack, snap, pop, click. That's what we think of having a kind of a chiropractic adjustment when we get cracked. This is what's happening. The adjustment itself is high velocity, meaning we want to do it really, really quick, but we don't want to use a lot of force. It's low force. So what happens, let's say, for example, now we have to deal with joint damage. Let's say, for example, we crack our own knuckles, or we adjust our own neck, or we twist our back. There really is potential where we can do more, there we go, more harm than good. We go from a good range of motion to a sprain or a bad range of motion. So I just bring this up. That's why we never encourage people self-adjusting, because if you don't know what you're doing, there's a potential where you're going to do more harm than good. Chiropractors, this is our bread and butter. We have the experience. We have the education to learn how to do this and learn how to do this effectively. So this is a long slide too, so we'll keep it quick. There's a lot of things that happen with a manipulation. We increase our touch receptors. We drown out our pain receptors. We increase our lymphatic drainage. There we go. And we can reduce inflammation in the joints. Increase our mobility, and that will decrease any irritation to the joint, increase any muscle spasms or trigger points that might be happening. So there's a number of things that go into the adjustment. So the effects of chiropractic manipulation in a nutshell: restores joint function, reduces muscle spasm, improves function, decreases inflammation. We're going to talk a little bit more about what's something called proprioception here. All of these together, we reduce pain, minimize pain, maximize function. So let's say, for example, a lot of people, oh man, I can't even imagine going to a chiropractor and getting snapped and cracked. That's okay. We have other methods that we can use that are effective methods. One of them that I use in the office is called an arthrostim. Now, with the raise of hands, there must be a number of you folks in here that have had this instrument used on you. It's called an activator. Click, click, click. Yes? Yeah, okay. So that's a show of hands. So what I use in my office, is the next generation of that. That's this arthrostim. Essentially what it's doing, it's an impulse. The arthrostim goes up against the joint line, and it impulses the joint, which creates freedom of movement in the joint. Another thing that I use quite regularly on low back patients when they come in is something called flexion distraction technique. Again, no cracking sound. We're not snapping and cracking. This is really good for herniated disc, for sciatic, for degenerative disc disease. Essentially what we're doing with that is that we're going to go from one end of the spine to the other end of the spine, and we stretch each segmental traction. We're tractioning out the joints. We go to the next one, and we traction out those joints. We want to make sure that all of the joints in the back are working as a team, one kinetic chain. If there's a weak link in the chain, then we're going to have problems. So this is a really good method to use. Again, no cracking. So now, if you look in your handouts, you see there's a 4-page handout on, I think it says back pain on the front from my office. I'll just, when you have a chance, look in the kind of the middle of that newsletter and the back, and it has a lot to do with the research. I left the research out up here because it's kind of dry, so you're welcome to look at it. But most of the research today suggests that the best way to handle back pain is through multimodal treatments. What does that mean? Multiple modes of treatment, using a number of different treatments in combination to have the best effect. So now there's a lot of people that can come in, a lot of people that can come into a chiropractic office and just get manipulated and feel better. Okay, so someone comes in, they have this upper cross syndrome, they get manipulated, and that you do feel better. But have we changed that upper cross syndrome? What have we done to affect change that upper cross syndrome? So that person may have to keep going back to the chiropractor, right? How can we do it so we get adjusted, we change whatever's causing the underlying problem, not have to get adjusted as much? I'm a big fan of that. As a chiropractor, I'm a big fan of that. We use massage therapy in the office in conjunction with manipulation. Patients have to be activated. We can't do it for you. You have to be activated. You have to be involved in your care. So we have active patient involvement. We also use ancillary modalities like your ultrasounds, your interferential, laser, all of those things we have at our disposal as well. So I'm going to talk a little bit about what's called something called functional rehabilitation. What does that mean? It's a little bit different than your kind of standard rehabilitation. So any form of rehabilitation, we generally want to work from the inside out. We're really concerned about the inside muscles first, and then we stabilize through the outside. There's something called proprioception. Proprioception is a perception or awareness of the position or movement of a body. So I have this proprioceptive test. So let's just do a little example of what proprioception is. Put your hands in the field goal position, if you would. Okay. I'm going to ask you to take an index finger Whoa, there you go. Index finger on one hand, and try to touch the middle finger on your other hand, but don't look. Close your eyes and try to touch the middle finger on your opposite hand. How close do you get to that middle finger? Okay, fantastic. Some people are going to hit that middle finger right on. Some people might be at their thumb. That's proprioception. How coordinated you are is proprioception. How close can you get to that? That's position in space. Yep. Okay. So proprioception is a combination of balance and coordination. If I stand on one foot, okay, my body is never perfectly still. I have this little dance with all of the proprioceptors in my body, from my ankle to my knee to my hip, up through my spine. When I do that, this stimulates the inside muscles to be kicked on. Did this go yet? I don't know if that went there. Yeah, the inside muscles to be kicked on, right? Shoot, I can't get used to this one here. It's different than my clicker. Okay, the inside muscles to be, I did it again. Can I go back? I guess it doesn't want me to go back. The inside muscles to get kicked on, and that's what I'm worried. I want to use those inside muscles. The name for those muscles are multifidi. They're the core stabilizers of our back. So when I do any exercise with a patient, now remember that last one and even this one, these are progressive. We don't start day one on trying to have you balance like that last slide you saw. It's something progressive. It's something that happens over time. We're working on your flexibility. We're working on your aerobic capacity. And when we get to the point, we tend to want to do things in a functional or a standing position. We perform these after manipulation because now we've stimulated all of the mechanoreceptors to be ready to take on a new engram, to take on a new memory. We stand on platforms. We start easy. This thing is a little squishy pad is called an Erex pad. Then we progress. When you're ready to progress, we progress to vestibular disc and Bosu balls. In this type of rehab, we want to use as many muscles and joints and body systems as we can, okay? That will help to, over the long term, that's going to help to create a new, good, positive engram and hopefully reduce your pain. So we want to progress to eyes closed, which challenges that system a little bit as well. Okay. Now we went from multimodal to multidisciplinary. Now it's not only one person working with you, it's a team of people working with you. So we typically start at the conservative management level. That can be anywhere from your primary care, chiropractic, physical therapy, any of your movement therapies. And look at the bottom here. I just want to kind of direct your attention to this bottom here. The clergy, psychologists, family, friends. How are they on your pain team? It's the emotional component. Again, we have to change the emotional component to pain. We have to start feeling better. If we're down in the dumps, we're not going to get better as quick as we should. Now, Joe comes into my office. He's got sciatica down his leg. I'm evaluating Joe, and Joe can't take a massage. He can't be touched. Certainly I'm not going to lie him down to do an adjustment. Okay, so I call on Dr. Beat, and Dr. Beat helps me through this first phase of treatment. This is co-treatment. This is your team working for you. Dr. Beat takes this person in and says, yeah, okay, well, let's do a epidural steroidal injection. Let's calm that tissue down. Let's do a facet injection. Let's calm that tissue down. Is that the end of your treatment? No. That calms the tissue down, you have to go back to rehab. You have to go back to stabilizing. So I lean on specialists all the time. It actually helps my job. It makes me look better when I work as a team. Surgery. So 20 years ago, I just started practice, and unfortunately, I was leaning over a patient, and I adjusted the patient, and I blew a disc out in my back. And Dr. Lepla referred to something called foot drop, okay? I had foot drop. I literally couldn't move my foot up, okay? It was paralyzed. There was total weakness there. Thank the Lord for Dr. Lepla. Now, here's the thing about chiropractic. We have this rap that we are anti-drug and anti-surgery. It's far from the case. We are an anti-drug and anti-surgical alternative. It doesn't mean that we're against those. What are we against? We're against the overutilization of any service, whether it be drug. In the case of chiropractic, I'm against a patient being seen 3 times a week for 12 years to feel better, okay? So we're against the overutilization. Now, we have this whole thing about, Dr. Lepla had mentioned about opiates. There's good and bad about opiates. The good thing is they work really, really, really well. The bad thing is they work really, really, really well. And so what happens is our body, our chemistry starts to change, and we get addicted. It grabs us, and it doesn't let us go. So I would suggest that, okay, my mom is in the hospital. She has pancreatic cancer. Fill her up with whatever makes her comfortable. There is a place for opiates. There's a place for that level of care. If I have a construction worker walking through my door every Monday morning and says, gee, doc, I have to take an OxyContin to get through the day, is there a better way to handle that? And I think all of our medical professions kind of understand that now. There's probably other things that can be done versus just taking the opiates. Now, I think Dr. Beat is going to talk about chronic pain. That's a different story. There's some other things that go along with chronic pain. But for the most part, I would just ask, use opiates as a last resort. So who is the foundation of your pain team? Who's the most important person in your pain team? Everyone. It's got to be you, right? You have to ask questions. You have to get answers. You have to advocate for yourself. If you go one place and you didn't get the answers, well, let's try another place. Let's try massage. Let's try chiropractic. The thing about chiropractic, too, I find, is that you give chiropractic, most people give chiropractic one chance. And if it doesn't work, you never see another chiropractor. If you go to a primary care and you don't particularly care for that primary care, you don't give up on medicine. You go to another primary care. So there's different chiropractors do different things. I just lend that to you because usually I just have one chance of grabbing you. And if it doesn't work, you give up on chiropractic. Don't give up on chiropractic. Okay, again, back clergy. Let's see. So that's supposed to be there. Okay. All right, so that's enough of that. So now the last thing, really quick, optimal health. So one of the common threads in this whole discussion was the physical, chemical, and emotional components to pain. It's the same thing that happens with our optimal health. We have this tripod. There's a physical, chemical, and emotional leg of our tripod. If one of those legs don't work, what happens to our tripod? Boom, it doesn't work, right? If all of these legs are working fine, then you're going to have homeostasis. Again, emotionally, if I am stressed out, I'm going to secrete more cortisol. My cortisol increases in the sympathetic response. That causes muscle tension, high blood pressure, all of those things. We have to balance out those systems, and they work as a team. Do you eat right? Do you exercise? Do you get enough sleep? Back to the stress management. Stress management. I can't emphasize that enough. Do you laugh? That stimulates endorphins. That's our natural pharmaceuticals. It's our inside pharmacy that we can look towards. Do you cry? Crying is quite cathartic. Crying increases endorphin release. It relaxes tension in our body. So don't be afraid to cry. If you laugh, if you spend time to think, and if you have your emotions move to tears, well, that's a heck of a day. Jimmy Valvano, anyone familiar with him? Okay, well, the only thing I would suggest is that the only thing I would add to this is if you move every day, that's going to be a fantastic day. Keys to optimal health, really quick. Being proactive versus reactive. What does that mean? I am not going to wait for my engine to fall out of my car before I change my oil. That's all that means. We want to be proactive. We want to do things before they get bad, right? We want to detect and correct small problems before they become big ones. I'm in my kitchen and I reach up and I grab a cup out of my cabinet and my back goes. Well, was it really that cup that caused the problem, or were there things underlying conditions that were setting you up for that straw that broke the camel's back, right? So we want to start dealing with these underlying conditions before we actually start to peak with pain. I'll leave you with a quote from one of my favorite movies, and if you haven't seen it, it's a must-see. I try to live this every day. If you treat a disease, we can replace the disease with pain. If you treat pain, you win, you lose. You treat a person, I'll guarantee you'll win no matter what the outcome. Does anyone know who said that? You'll know in a second. Patch Adams. Great movie. If you haven't seen it, I would suggest taking a peek at it. Thank you so much for your time. I really appreciate it.